Hello everyone, this is Dr. Uma. Today I'm going to discuss about two topics which comes under the congenital heart disease of the children. Those are patent ductus arteriosus and atrioventricular septal defect. Before moving to the main topic of today, you need to understand what is congenital heart defects and what are the types like asymptotic lesions and symptomatic lesions. What is the meaning of left to right shunt and right to left shunt? Regarding these things, I have updated 2 to 3 videos. I would like to give link in description box. Kindly go through that. So moving to the topic, patent ductus arteriosus. In short term, we can say PDA. First, we will see about the definition. Ductus arteriosus is nothing but it's a normal fetal vascular connection between the pulmonary artery and aorta. After the first breath of the baby, normally it closes, but due to some other reasons, if it doesn't close, then that connection remain present. Okay, so that's why we are telling this is a patent ductus arteriosus. Patent means present. So ductus arteriosus is still present. This is the meaning of the definition. So this create abnormal communication between the artery, I mean pulmonary artery and aorta. This allows the blood between these major vessels. So if you talk about the pathophysiology, then it is having some steps, like first of all, ductus remains pattern in post birth. It means after the birth also, there is a connection between the artery, pulmonary artery and aorta. So which allows the blood moving from high pressure aorta to the lower pressure pulmonary artery. So basically, comparing to pulmonary artery, aorta is having higher pressure, right? So aorta carries the oxygenated blood. So generally, because of this, the hole or opening between two, so oxygenated blood is moving from aorta to the pulmonary artery. So once it is reaching to the pulmonary artery, so what will happen? Definitely, during the third step, the blood which is coming from the aorta, it is moving to the lung. From the lung, it is after purification, again it is coming to left side atrium, then left side ventricle. So this is the reason that left side of the heart is getting overloaded. So during the fourth stage, what is happening? Pulmonary hypertension and congestive heart failure and possibly Eisen-Menger syndrome, if untreated, will be developed. Next, I would like to discuss about clinical manifestation of PDA. If you think about infant, continuous missionary murmur, we can hear, especially at the left upper sternal border. Hyperdynamic pericardium also we can see. It is nothing but it's one kind of clinical finding characterized by forceful high amplitude and fast acting heart impulses on the chest wall. Then third important manifestation is bounding pulses. What it is, it's a strong, forceful or a throbbing heart rate felt in arteries, often caused by increased blood flow, cardiac output, high or any other anxiety disorder to the children. And tachypnea also will be present. Poor feeding will definitely leading to fatigue and faltering growth. Otherwise, we can say failure to thrive also when we present for the infants. When you talk about older children, excess intolerance will be present. Excess intolerance means when the children's moves otherwise active, they feel fatigue continuously, and palpitations and awareness of heart pounding will be present. Recurrent respiratory infection can also caused by pulmonary congestion. Cardiomegaly can be visible. Congestive heart failure also will be present if untreated. Next, moving to diagnostic evaluation of PDA. The first one is the physical examination. Auscultation reveals classic continuous missionary murmur, I already explained, and palpation shows hyperdynamic pericardium and bounding peripheral pulses with wide pulse pressure. And second one is the chest X-ray. it can demonstrate cardiomegaly. And the third one is the electrocardiogram. In electrocardiogram, we can see widened QRS complex. This picture shows the widened QRS complex, and it may show left atrial enlargement in long standing cases. And fourth one is the echocardiography. Here, we can see size, shunt direction, and chamber dimensions also. Doppler confirms left to right shunting. And finally, cardiac catheterization. Through this, we can see pulmonary artery pressure, quantifies shunt magnitude, and evaluates operability before intervention. If a child is about to post to operation, we can confirm the actual cardiac condition through the cardiac catheterization procedure. Next, we will talk about management of PDA. Medical management, indomethacin or ibuprofen, we can give. This is a prostaglandin inhibitors promoting ductal closure. Also, it is very effective in preterm neonates when it is administered within first week of life. If heart failure support needed, then we can go for diuretics. For fluid overload, fluid restriction protocols we need to follow. Controlled oxygen therapy should be given. Respiratory and cardiac status should be monitored continuously. Then interventional management, I mean any surgical management. The first one is the catheter device closure. Under the catheter device closure, we can go for coil, otherwise occluded device deployment. You can see this picture. Coil looks like this, and devices looks like this. It can be fixed in the heart through the tube which is inserted by inferior vena cava. And this is very important procedure for especially older infants and other childrens. And the hospital stay will be very less, and rapid recovery will be possible. Then if this catheter device closure is not possible, then we need to go to surgical ligation, open surgical thoracotomy approach, otherwise direct ligation of patent ductus also can be possible. We are moving to next condition, which is atrioventricular septal defect. In short term, we can say AVSD. So what definition says, it's a complex congenital heart defect involve failure of endocardial cushion development during embryogenesis. Embryogenesis is nothing but it's a fetal heart development period. During the time, if anything, something happens due to this, endocardial cushion is not developed properly. You look at this picture here, heart is having only one chamber. There is no separation between atrium and ventricles. Okay, so this is called a endocardial cushion development failure. So this result in malformation of atrial septum, ventricular septum, and atrioventricular walls, including mitral and tricuspid. Okay, here, so there I already said that there is no connection, proper connection between the ventricles and the atriums also. So it is having two types. Number one is the partial AVSD and complete AVSD. So this picture shows the complete AVSD. So in partial AVSD, what will be there? First of all, incomplete endocardial cushion will be there. So especially there is a involvement of atrial septal defect. I mean premium atrial septal defect will be present, and abnormalities of AV walls also will be present without ventricular component. Okay, here connection will be present, like blood is moving from the left side atrium to the right side atrium, and also ventricles will be not separated properly. And this condition especially present in the Down syndrome children, I mean trisomy 21, and 40 to 50% of children with Down syndrome will have AVSD. Then what is complete AVSD? In complete AVSD, large premium ASD will present. See, completely this lower part of the atrium, there is a complete connection between the left side heart to the right side heart, especially in atrium. And inlet VSD also present, and a single common AV valve replacing separate mitral and tricuspid valves. Here there is no valves and especially tricuspid and mitral valve. So only one chamber is present. So total mixing of blood, I mean pulmonary and atrium blood. Next, we'll discuss about pathophysiology and the clinical features of AVSD. The first one is the defective septation will be there. I mean, failed endocardial cushion development. It creates the arterial and ventricular septae. It means a defective septum development between both atrium and ventricle. Then large left to right shunt will be there. Large to left shunt in the sense the blood is moving from the left to right side of the heart. Left heart carries the oxygenated blood and the right side carries the deoxygenated blood. So basically blood is getting mixed. Okay, blood flows from the left heart into common AV wall, both ventricles. And then third one is the pulmonary over circulation. So there is no controlled circulation in the pulmonary artery, so definitely it will increase the pulmonary blood flow, so overload will be present. So I already explained that from the pulmonary artery, the blood is going to the lungs, it is coming back to the atrium and ventricle. Of course, it increases the left side heart failure because of overload. And the fourth, especially progressive volume overload leads to congestive cardiac failure. And finally, pulmonary hypertension also will be developed. So, Eisenmenger syndrome will be developed only if it is not treated or it is not corrected only. Okay, what is Eisenmenger syndrome? Basically, reversal of the pathophysiology of the heart disease. For example, I already said that heart is moving, I mean blood is moving from the left side to the right side. If it is not treated because of the overload, this can be turned into right to left side of the heart blood moves. Okay, this is called Eisenmenger physiology. So when we talk about clinical features, tachypnea and respiratory distress will be present, excessive sweating especially during the feeding time, and poor weight gain will be there, faltering growth, and then recurrent pneumonia and lung infection may be developed, heart murmur, systolic and hollow systolic will be there. Then cyanosis in late stage, only when the child developed Eisenmenger syndrome, then only cyanosis will be noticed, because these conditions like ASD, VSD, AVSD and PDA are the acyanotic heart disease. Cyanosis will not be present once it is developed, I mean complicated manner like Eisenmenger syndrome is developed, then it can be cyanosis for the children. The next one is the diagnostic evaluation of AVSD. Physical examination, we can find out the ventricular impulses, I mean hyperdynamic. Pericardium, we can find out hollow systolic murmur. Also, we can see especially in the lower left sternal border, and signs of heart failure, including hepatomegaly, we can find out. And the chest radiography shows the cardiomegaly, and it is like egg on side appearance, we can find out. And the electrocardiogram, superior axis deviation will be find out, left axis deviation will be present. And echocardiography, definite visualization of septal defects, common AV wall morphology and shunt severity we can find out. Cardiac catheterization is very important before the surgery to understand the complete scenario of the heart. Then management, medical management, diuretics, I mean furosemide, we can give AC inhibitors like captopril can be administered. This will reduce the afterload, and a digoxin should be given if myocardial contractility is not proper. To improve the myocardial contractility, we can go for digoxin. Nutritional support, definitely proper calories they need. Nasogastric feeding can be also used. Oxygen therapy should be given, I mean controlled, otherwise monitored supplemental oxygen should be given. And complete surgical repair can be done especially before the 6 month. Okay, then otherwise child can go for severe problem in the heart due to the irreversible pulmonary hypertension. So what are the procedure available? One is the ASD closure. So it is having nearly three conditions, like ASD is there, VSD is there, AV valve reconstruction also should be done. So we can go one by one, like for a premium defect repair with patch can be done for the ASD closure, and for the VSD closure we can go for inlet defect closure avoiding AV conduction tissues, and AV wall also should be reconstructed. Okay. And next we'll see about some of the nursing responsibilities. Basically pre-operative monitoring we should be done, like respiratory rate, distress assessment, then feeding tolerance, intake, documentation should be done. Daily weight monitoring will be very mandatory, because growth retardation is the very important problem. Once the child didn't have expected weight, then we cannot go for surgical repair. And medication should be administered very safely. Cardiac arrhythmia monitor should be done. Infection should be controlled. Oxygen saturation should be maintained. Pain management should be done. Fluid and renal function should be checked properly. And of course parental education also very important. Thank you so much for listening this video. Thank you.